This presentation is called Antimicrobial Stewardship Programs. Are we forgetting something? My name is Dr. Timothy Wiemken, Associate Professor in the University of Louisville School of Public Health and Information Sciences, Department of Epidemiology and Population Health. I'm going to take a slightly different approach to this and tell a story in 3 acts. As a spoiler, there's no resolution, and you might notice over time that this story plays out much like a horror movie. Act 1 is called The Curse of the Thoughtless Person. So as far back as the discovery of penicillin, the first antibiotic that we ever used, mass-produced and used in humans, Fleming, who discovered it, said the microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted. So it's pretty interesting that even really before we were using penicillin widespread, we were concerned about resistance to the drug. And Fleming is famous for essentially stating that there was no drug ever to be created that some organism wouldn't become resistant to. So essentially, everything is going to be resistant to everything. You'll find out why that is later. So unfortunately, we ended up morally responsible for this alphabet soup of multi-drug resistant organisms. It seems like there's a new resistant organism identified every week. But so we've really ended up in this quite conundrum. We feel like we have a pretty good idea of how antibiotic resistance happens. There are a lot of germs, or bacteria, parasites, viruses, fungi on our body. We're just going to talk about bacteria primarily in this presentation. So if we think about our bodies, and we're made up of cells, actually we have more bacteria in and on our body than cells that make up our body. Actually, probably somewhere between 10 and 100 times more bacteria than cells that make up our body. So we're mostly bacteria. Some of these are inherently drug resistant, or they've become drug resistant over time. If we take any antibiotic, or if we take any antimicrobial agent, be a skin antiseptic or whatever, those are broad spectrum killers, which means that they kill everything, not just what we want them to kill, but also our normal bacteria. We have normal bacteria. Not everything that we have is pathogenic. So when we take an antibiotic, it kills the good bacteria, it kills the bad bacteria, and those good bacteria are actually preventing infection, right? So they're occupying receptor sites, and they do a lot of other good things too, like make vitamins and different things, help us digest food. So if we don't replenish the normal flora, these drug-resistant bacteria are really allowed to grow and take over, right? They occupy the receptor sites that the normal flora used to occupy. Furthermore, some of these bacteria can actually give their drug resistance genes to other bacteria, and that causes more problems by promoting resistance very quickly. So we also know that antibiotic resistance is ancient. It's been around forever, as far back as the creation of bacteria, or the evolution of bacteria. They've been warring with each other. So most of our antibiotics that we have now are derived from bacteria who are already producing them. And that's because they're producing them to kill each other. They're fighting with each other. So most resistance that we see now isn't necessarily developing. We're just selecting for it. It already exists. We're just selecting for it. Some is new resistance, but most of it is just selection for already developed resistance. A good timeline of this is outlined here. In the 1880s, we discovered this new pathogen, which now we consider probably one of the most important human pathogens, Staphylococcus aureus. In the 1890s, we started researching Penicillium, and that is the organism that we derived penicillin from. In the 20s, Alexander Fleming started publishing on penicillin and its potential uses as an antimicrobial agent. And very shortly after that, in the early 40s, we began mass producing penicillin for use in humans. And just a couple of years later, we saw the emergence of PRSA. And PRSA stands for penicillin-resistant Staphylococcus aureus. So again, this organism didn't develop resistance this quickly. We just selected for it through our mass use of penicillin. Shortly thereafter, in the 50s, we started developing a new antibiotic called Methicillin. And then again, in the early 60s, we saw MRSA, methicillin-resistant Staphylococcus aureus. In the 60s, we started using vancomycin to treat patients with MRSA, and it took a while, but eventually we saw vancomycin-resistant Staph aureus, VRSA. So why is it that it took vancomycin so much longer, or Staph aureus so much longer to develop resistance to vancomycin? Well, there are a lot of arguments for this. Possibly, during this time was when we started our antimicrobial stewardship activities to develop processes for the prudent use, the appropriate use, limited use of antibiotics. And really, we started because of our issues with penicillin and methicillin and several other antibiotics. We started using vancomycin more judiciously, and that probably delayed the identification of vancomycin-resistant Staph aureus. Again, organism was probably already resistant to it, but we finally just selected for it. Alternatively, it could have developed during this time, which would also explain the length of time that it took from the mass use of vancomycin to the emergence of VRSA. Yet another way to look at this, on the top of this slide, we see the years that a particular antibiotic or class of antibiotics was really deployed in the human population. On the bottom, we see the years that resistance was identified in bacteria, causing infections in human beings. So you can see that pretty much every antibiotic or class of antibiotics that we've deployed, we've identified organisms resistant to those antibiotics. And again, that's because we're selecting for them with our overuse of antibiotics. So this is truly a global pandemic, antibiotic resistance. If we look at tuberculosis, a very, very concerning organism that causes many, many deaths worldwide, we see that in countries, in continents like Asia, we have over 18% of the tuberculosis cases are multi-drug resistant. This is very concerning because tuberculosis is difficult to treat. Typically, if you have active tuberculosis, you're going to have someone come to your house and give you 3 or 4 different drugs to treat the organism. And if it's resistant to those, well, we're already using 4 drugs. It's getting more and more difficult to treat. A very concerning issue here is these white countries where there are no data that are reported. Of course, as we know, we have to have data to be able to develop any particular intervention and to see if it's successful or not. So there are a lot of countries where we have no data, or really subnational data, or just very, very small amounts. And again, we can look here and see this is truly the spreading scourge of antibiotic resistance. So, and again, large areas of the world where we have really no information obtained, those gray countries or even the orange countries where there are no national data, just very local data, particularly in India where we see a lot of resistance. We have to have these data for successful intervention development. Without our data, we have no baseline and we have no basis for development or evaluation of our interventions. So as we move forward, this becomes probably more and more of an issue. If we look at the expected number of deaths attributable to antimicrobial resistance each year by 2050, in Asia, 5 million, Africa, 4 million. I mean, millions and millions and millions of individuals dying each year because of antibiotic resistance. So let's take a step back. 1879, California. If you think about what was going on in California in 1879, well, Edison was pretty active in his work. And this is when he discovered the incandescent light bulb. And there's this famous quote that he may or may not have said. It's been paraphrased for many, many, many decades. He said that, "I've not failed, I've just found 10,000 ways that it won't work." So he refused to state that he failed. He just said, I tried a whole bunch of times and I found a bunch of ways it didn't work, right? Finally, I found the one way it did work. So when we talk about failure, I will go ahead and say that we've failed with our use of antibiotics. We've had a lot of opportunity, and is something as simple as this particular slide, that every antibiotic we've ever used, we've identified organisms that are resistant to that antibiotic causing infections in humans. This could be thwarted. It could be reduced significantly with appropriate use. So when we talk about antimicrobial resistance, we're talking about an umbrella term that includes antibiotics. Not all antimicrobials are antibiotics, right? So all antibiotics are antimicrobials. So there are other antimicrobial agents. Antimicrobial means anything that kills a living thing, or a microbe, particularly bacteria in this case. So disinfectants are also antimicrobial agents. So we use disinfectants all over the place. If you look in your house, you look under your sink, you probably have some sort of disinfectant. You either have bleach, or you might have a pop-up wipe that is pre-saturated with a particular disinfectant, usually a quaternary ammonium compound, and it says kills influenza virus in 30 seconds, kills E. coli in 1 minute. So those are all disinfectants, and we use those all the time. So what's the situation with this? Well, we have resistance to disinfectants. This is a very big concern, particularly in healthcare environment where we're using lots and lots and lots of disinfectant every day, multiple times a day. So we do have resistance to disinfectants, also known as biocides. Skin antiseptics are another antimicrobial agent that we tend to not think about too much in terms of antimicrobial stewardship. This is unfortunate because we use a lot of skin antiseptics at home and in the healthcare setting, particularly chlorhexidine gluconate, even available over the counter at any pharmacy in your area. We use this in hospitals a lot for bathing of patients as opposed to using soap and water because it's a broad spectrum antiseptic, trying to reduce the burden of bacteria on an individual's skin to try to reduce their risk of getting an infection. But what we're also doing is overusing a broad spectrum antibiotic, much like we did with penicillin. So what has this resulted in? Well, it's resulted in resistance to chlorhexidine gluconate in many, many bacteria. There are a lot of reports of resistance to chlorhexidine now. Of course, Edison ended up coming back around and saying that, we do fail occasionally, but it's not necessarily just a bad thing. He said failure is the most effective technique to optimize strategic planning, implementation, and processes. So what does this mean? It means if we fail, we can actually look back on the process and make it better, essentially. Helps us plan better for the next intervention, helps us implement that intervention better, and helps us evaluate that. So because of all this, the Centers for Disease Control and Prevention have released these core elements of effective antibiotic stewardship program. Again, this is antibiotic stewardship program, not antimicrobial stewardship program. So we're just focused on antibiotics here. So they have these 7 areas: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. And all these areas are critical to appropriate antibiotic stewardship programs to make sure that they work well. So what's being done in this area? So if we look at this, percentage of U.S. hospitals implementing all 7 core elements of the antibiotic stewardship program by each state. And if you look around, you can see Kentucky, our state here, 31 to 45% of the hospitals in our state are implementing all 7 core elements. And again, remember that every hospital is supposed to be implementing all core elements. But if we look through, we have several states that are very low as far as who's implementing what. And even in the highest, we're looking at 60%. So that's not very good. We have a lot of room for improvement. And if we look at this is kind of an aggregate percentage of hospitals reporting the implementation of those core elements broken out by the element themselves. So we have these 3 that are more focused on infrastructure, and then these 4 that are focused on implementation. So leadership is the lowest of the bunch, unfortunately. It looks like a lot of people are taking action, but much fewer are tracking the action, and fewer are reporting, and even fewer are doing education. This is unfortunate. So when we talk about antibiotic stewardship programs, they should say antibiotic stewardship programs, we have four key elements. We have the right drug, the right dose, the right duration, and the right route. So you have to select the right drug for the organism you're trying to kill. You have to select the right dose to make sure that you have enough of that drug in the particular area where that organism is so it gets killed. You have to use it for the right amount of time to make sure that you've sufficiently had enough drug in the right dose in that particular area. And the right route. Are you going to use an oral drug, an IV drug, an injection to make sure that it penetrates the area it needs to get to? So unfortunately, all of these elements are related to identifying the particular pathogen. So why is this an issue? This is an issue because we rarely identify a pathogen in patients with infections. This varies based on the infection type, of course, but for example, community-acquired pneumonia, or pneumonia and influenza combined, are the leading cause of infectious diseases-related death worldwide, so very concerning infections. In community-acquired pneumonia patients, we identify a pathogen somewhere between 40 and 60% of the time. So somewhere around half of the patients, we never identify a pathogen, which makes it impossible to identify the right drug, the right dose, the right duration, and the right route. We settle on empiric therapy, or what we're guessing might be the likely pathogens that we need to get rid of. And because of that, we tend to use more broad-spectrum antibiotics, and because of that, more of the normal flora gets killed. So this perpetuates this cycle of antimicrobial resistance. So Act 2 is called The Curse of the Outpatient. So we've been talking a lot about what's happening inpatient, in the hospital setting, but what's going on outside of the hospital? Well, first we're going to take a step back and we're going to look at Ethiopia. One thing we know is that Chlamydia trachomatis is the most common cause of infectious diseases-related blindness worldwide. And of course, blindness is a very concerning issue. So this Chlamydia trachomatis is a bacteria. So these individuals decided to try to treat different groups of people with azithromycin. Azithromycin is a antibiotic in the class macrolides. So macrolide antibiotics include azithromycin, clarithromycin, azithromycin, and some other things. So this particular drug treats Chlamydia trachomatis quite well. You might have heard of this drug. You might have actually received this drug many times in your life. You might think of it called a Z-Pak. We get those a lot if we have upper respiratory tract infections from individuals who may not be practicing appropriate antimicrobial stewardship. So since Chlamydia trachomatis is a big issue in Ethiopia and there's a lot of blindness, they decided to implement this intervention where children in these areas got one dose of azithromycin. So a typical azithromycin is 2 doses on one day and then 3 more doses on consecutive days thereafter. So usually we don't get too much of this. So we're even looking at less of this. So 1 dose of azithromycin every 3 months for 1 year. So that's very, very few drugs, very, very little amount. So a lot of children carry this organism Streptococcus pneumoniae in their oropharynx or their nasopharynx, kind of the back of their throat. So this organism is very concerning, not necessarily in children so much. It can cause infection in children for sure, but they tend to pass it on to adults, and this organism is the leading cause of community-acquired pneumonia worldwide. So we definitely want to try to prevent this organism from transmitting around, but moreover, we want to prevent this organism from being resistant to antibiotics because we don't want to cause a multi-drug resistant or a drug-resistant Streptococcus pneumoniae pneumonia in an adult. So because they were doing this intervention where azithromycin was being given, and we're very concerned about macrolide resistance in Streptococcus pneumoniae, they decided to look at what was happening with macrolide resistance in this organism during this particular study, since they were using the drug. So like any good epidemiologic study, they had a baseline, and they looked at the rate of macrolide resistance in these children, the prevalence of macrolide resistance in these children. That was about 4%. So 4% of the kids were carrying a macrolide-resistant strep pneumo in their throat at the beginning of the study, before any antibiotics were given. Like an even better epidemiologic study, they had a control group. So this group went through the entire study without being treated. No one got azithromycin. And the rate of prevalence of macrolide resistance there was about 6%, so still pretty close. Now, after 1 year of giving one dose every 3 months, so again, a very small amount, 46% of those individuals were carrying a macrolide-resistant Streptococcus pneumoniae. So obviously a huge difference. And this is a very small amount of antibiotics. So this is called selection pressure. Selection pressure is when there are a lot of antibiotic around and it's killing all the normal flora, it's suppressing the normal flora, and it's killing off the susceptible organisms at a very slow rate, and it allows the resistant organisms to grow and flourish. So even with a very small amount of drug, inappropriate use at essentially a subtherapeutic dose for an infection is going to induce a lot of pressure on the normal flora and allow resistant organisms to flourish. So we can look at some other studies and see that we have the total antibiotic use and resistant organisms are pretty much a linear relationship, right? So this is a study published in Emerging Infectious Diseases looking at Streptococcus pneumoniae, that's the same organism that we saw last time, and Streptococcus pyogenes, another species of the genus Streptococcus. So as we use more macrolide on the right, you can see that we see more macrolide-resistant Strep pyogenes worldwide. Same with macrolide-resistant Strep pneumo, and the same with penicillin non-susceptible Strep pneumo. So the more antibiotic we use, the more resistant organisms we see. This has been shown over and over and over again. So again, I said we were going to talk a little bit about the outpatient setting as well. Outpatient setting, doctor's offices, corrections, behavioral health. So here's a map. Again, it's a little dated at this point, but the trend is pretty much the same. This is antibiotic prescriptions per 1,000 persons of all ages by state. If we can look at Kentucky, here we see that we're somewhere in the 1,000 prescriptions per 1,000 persons of all ages. So what does that mean? That means every individual in the state is getting a prescription every year. This is a big deal, very concerning. And again, even on the low end, 529 is the low end, right? So 500 divided by 1,000, pretty much 1 in 2 people are getting an antibiotic prescription every year. So although there are different colors on this map, would say that every state is doing pretty poorly as far as antibiotic prescriptions. Treatment trends worldwide, we see pretty much the same issue. First, focus on these gray areas, huge areas of the world where there are no data reported at all in terms of antibiotic doses given. Again, some of these areas, a lot of these areas, you can actually buy antibiotics over the counter, where here in the United States, we typically need a prescription. And here you can see countries like Saudi Arabia and South Africa, we're looking at somewhere around 40,000 doses of antibiotic per 1,000 people. That's 40 doses per person per year. That's a lot of antibiotic, a lot of selection pressure that's in these areas. So to evaluate what we've been doing, there's a lot of interventions ongoing as far as how do we best promote antibiotic stewardship programs. What are we supposed to do? Are we supposed to do education? Are we supposed to have guidelines? Are we supposed to reduce our formulary, have computerized decision support tools? Well, the VA system in the United States did a systematic review of pretty much all the literature and looked at all of these interventions that we've been doing in the outpatient setting. And across all the studies that were published, we found that there's really very, very low evidence that any of this works. So what we've been doing for many years in terms of antimicrobial stewardship, antibiotic stewardship in the outpatient setting has not been working. So again, our outpatient stewardship activities are not really working. They're working a little bit, but there's very low evidence to support that they should be continued. So why do we keep doing the same thing over and over and over for years and years? That report was published in 2014. We're still doing the same things in 2017. So as Einstein would say, insanity is doing the same thing over and over again and expecting different results. So Why are we expecting different results when we're doing the same thing? It's time to look outside of the box. Like Henry Ford said, if I asked people what they wanted, they would have said faster horses. They weren't thinking outside of the box. They just thought that horses were how they were able to transport from area to area. So we certainly need different individuals to come in. We need to innovate. We need to think about different ways to improve antibiotic stewardship. And some people have been thinking about this for a very long time. It just hasn't been implemented as well. We know there are ways that new things get diffused through a population, and people uptake things at different time periods. Right? We have innovators, very few people in this bell curve who are developing new things, really innovating new stuff. And then we have the early adopters, a big chunk in the beginning. Those are the people that are up at 3 a.m. every morning in September ordering their new iPhone. The early majority and the late majority, this majority of people, that's why it's called the majority, this is really where people are sitting back and they're thinking about things a little bit more before they actually adopt anything. And then the laggards. So what moves any particular innovation or any new thing through these stages? If we look back at the Coleman and Katz study, but they looked at this study, they called it the Medical Innovation and Diffusion Study. So they were looking at how this new antibiotic at the time, tetracycline, was being picked up and diffused and used through the medical community. So at the time, they did all kinds of research and they did these social network analyses. And what they find? They found that peer pressure was the main reason that people were starting to use this new antibiotic. So if your friends used it, then you were more likely to use it. So peer influence is obviously critical. And it's not just peer influence in terms of peer pressure. It's just if you perceive that someone is doing something, you're more likely to do it. So this is something that hasn't been used so much in antimicrobial stewardship, antibiotic stewardship programs, that we may be able to focus on a little bit in the future. Because again, it's old data, and we just haven't done it yet. We know that these analyses are possible. We've done several studies here at the University of Louisville looking at infection prevention in the hospital and how information is being diffused through these particular networks. We're able to use some new technologies and new study designs to identify key individuals who might be better at diffusing information, who might be better trusted. And of course, trust is a critical aspect of diffusing of information. You're more likely to actually implement something or change your behavior from information gained from somebody if you actually trust that individual. So Act 3, the curse of repeating history. So we talked a lot about antibiotics, and we know there are a lot of different antibiotics, and different antibiotics are used for different infections to kill different organisms. They all act a different way. And similarly, we have a lot of different disinfectants and skin antiseptics. So particularly, again, like check out in your house sometime and see the different disinfectants that you have. Anything that says kills this organism in X amount of time is an antimicrobial agent. So we have these different categories of disinfectants, and we use these every day, in every setting. From the antibiotic perspective, we know that different antibiotics act on different areas of a particular organism. So you might have a quinolone antibiotic like ciprofloxacin or moxifloxacin, or those act on the DNA gyrase of the organism. DNA gyrase is an enzyme that curls up the DNA into a nice little ball. So if that doesn't happen, the organism dies. You might have azithromycin, like we were talking about earlier. The macrolide azithromycin acts on the 50S subunit of the ribosome. And what that does is it prevents the messenger RNA from being translated into protein. And of course, the organism is going to die then. Things like penicillin that we talked about in the very beginning work on the cell wall of the organism. So different organisms are going to be inherently resistant to some antibiotics because particularly gram-positive organisms like Staphylococcus aureus have a very big, thick cell wall, and therefore antibiotics that interact with the cell wall, like penicillin, cephalosporins, carbapenems, those work very well in gram-positive organisms. In gram-negative organisms, which we haven't talked about too much, but they don't have a very thick cell wall. So these antibiotics that act on the cell wall don't work so well in gram-negative organisms. So selecting the right antibiotic can be very difficult for a particular organism. But again, the important thing is to remember that all of these have some larger spectrum of activity than just killing the organism of interest. We have no antibiotics that can kill a single organism and only that particular organism. Everything has some sort of collateral damage, and it kills the normal flora as well. So that was antibiotics. So what about antiseptics and disinfectants? Well, each antiseptic and disinfectant works on a particular area of a bacteria or a fungus or a virus or a spore or whatever it might be. So just like an antibiotic. So it goes to show that development of resistance is pretty much the same as with antibiotics. So why we haven't thought about this is very concerning, and why we're still using lots of broad spectrum disinfectants and antibiotics a lot is very concerning. So we can see our very common disinfectants, chlorhexidine, quaternary ammonium compounds, QACs. Those cause leakage of the intracellular components of the organism. You get all of your important components of the cell leaking out of the organism. Obviously, it's going to die. So we have probably a lot more disinfectants than we have antibiotics, and there's a lot more opportunity for resistance. So we can't forget that disinfectants and antiseptics are also antimicrobial agents. Antimicrobial is an umbrella term that includes anything that kills a microbe. So our stewardship programs really need to be inclusive of not just antibiotics. We need to really truly think about antimicrobial stewardship programs and not just antibiotic stewardship programs. Because if we lose our disinfectants and antiseptics as quickly and as broad spectrumly as we've with our antibiotics, we're going to be in a lot of trouble. There's going to be pathogens everywhere in the environment. Günter Kampf in Germany has been thinking about this as well. So he published a study recently in the Journal of Hospital Infection looking at chlorhexidine and acquired resistance to chlorhexidine. His idea was, is it time to establish an antiseptic stewardship initiative? Of course, I would make a broader step and say we need to develop an antimicrobial stewardship initiative that includes antiseptics and disinfectants. But really an important part of this paper was this particular table, Table 2. If we look through these several countries that he's listed out here, just looking at Staphylococcus aureus, MRSA, and looking at the number of a certain number of isolates, and then how much QAC A and B was identified. So QAC A and B are genes that the organism has that confer resistance to chlorhexidine and also quaternary ammonium disinfectants. So if we look through here, there's a couple of duplicate studies. These are all different studies, right? So we can look through here and we can see that we're looking somewhere with 80%, and then some other studies in the United States have very low rate. But if you look up in the middle, we have a USA that's 18%. So the variation in quaternary ammonium and chlorhexidine resistance is certainly there, but it's also a large burden, particularly in Southeast Asia, Malaysia, China, and also in South America and Australia. Yet we continue to use this antiseptic a lot. So in the United States, there's a large push for daily bathing with chlorhexidine, either in a liquid form or in a presaturated cloth, and that takes the place of soap and water. Twice a day, every patient gets bathed. So this is a large-scale use of a very broad spectrum antimicrobial agent. And of course, as we know from our use of penicillin and our use of methicillin and our use of vancomycin and our use of all the other antibiotics that we talked about, that we're going to have a large amount of selection pressure, and we're going to select for resistant organisms. So it's going to be, in a very short time, we're going to lose our ability to use chlorhexidine because everything's going to be resistant. So again, because our stewardship activities should be inclusive of antimicrobials like disinfectants and skin antiseptics, we need to come up with new ideas on how to thwart the issues with selection of resistant organisms and development of resistance. And I would say really our approach can be similar with antibiotics and disinfectants and antiseptics because they're all antimicrobial agents. Of course, as we looked at before, the approaches we've taken, particularly in the outpatient setting, aren't really working. So that's kind of concerning. So if our efforts aren't working, we really need to innovate and develop some new things. But when we do find something that works, I do think that our approach to antibiotics and antiseptics and disinfectants can be very similar. So why is this? I think it's because there are also 4 critical components in an antiseptic or disinfectant stewardship program, right? So we have the right drug, the right dose, the right duration, and the right route. So our disinfectants and our antiseptics are really, again, they're antimicrobials, the same as antibiotics. So if we look at the right drug, we need to find a particular disinfectant, that's the drug, that has the right drug to kill what we want to kill. And that has to account for surface compatibility. So we have some disinfectants that work on soft surfaces, some that work on hard surfaces. We have to think about resistance. Are we using a quaternary ammonium compound where most of the organisms in the environment are resistant, etc. So again, if you look at a hospital now, you see a lot more soft surfaces. And as hospitals become more and more hotel-like, you see even more leather couches, fabric couches, these kinds of things. And of course, forever we've had privacy curtains. Privacy curtains are all soft surfaces. So what's the issue with this? Well, soft surfaces are, they act a little bit differently than hard, non-porous surfaces. So Bill Rotella at the University of North Carolina has done a lot of work with soft surfaces, particularly in these privacy curtains. And the privacy curtains that he's looked at have all been very, very filthy. Lots of bacteria on those. And unfortunately, prior to very recently, there are very few effective and EPA-approved disinfectants for soft surfaces. There's only a few now. As of a couple of years ago, there weren't any. So this is a ripe area for research and really a strong area of need, because even at home or in an outpatient setting, it's much less regulated in terms of what types of materials you have. So if you look at a doctor's offices, you're going to see a lot more soft surfaces than even in a hospital. And then when you get home, you're going to see even more. So the disinfectants that we try to use may not work. It may say it kills influenza virus in 1 minute, but if you look very closely, it's going to say on a hard, non-porous surface. And that's probably very few of the surfaces in our house. We also have to think about the right dose. So a lot of disinfectants and even antiseptics in the hospital or at home need to be diluted. So you might have heard of a 10-to-1 bleach solution or whatever it may be. Even quaternary ammonium compounds are typically diluted. So it means you get a concentrated amount of this particular disinfectant, you put it in a bucket, and then you pour water in it to dilute it to a certain amount, and then you're able to use it. So this is in contrast to ready-to-use these pop-up wipe type of things that you probably have at your house with a pre-saturated wipe. So we looked at this particular issue in a local hospital here in Louisville, and they were using a dilutable disinfectant quaternary ammonium compound, and it was very cheap, but there were several process issues related to this. We called this the bucket method because we were pouring it into a bucket and then diluting it. So the issues that we saw were people were saying, oh, there's too much, the smell is too strong, so I put a little bit more water in it, or I think that it's going to work better if I put less water in it. So all of these issues affect the efficacy of that particular product, and these are very concerning issues. So what we decided to do was switch to a ready-to-use, these pop-up wipes, RTU, ready to use. And what we found was, although the upfront cost of these pop-up wipes were really a little bit more expensive, obviously, than the cheap, just undiluted disinfectant, really ended up being a lot cheaper because now you have these pop-up wipes. You don't have to worry about laundering cloths. You don't have to worry about buying cloths. You don't have to worry about buying new buckets or destroying buckets or all of these things. But we also found that compliance was actually increased because people didn't have to think about how much liquid was on this particular rag, or when do I need to switch rags, or use go back down to the basement and get a new bucket of disinfectant. So it actually took people less time to clean the rooms, which is very nice because then rooms can get cleaned better and new patients can come into those rooms in a much cleaner room. So it ended up saving costs over a very short amount of time. We also have to think about the right duration. So like an antibiotic, we have to think about, are we going to use it for 3 days, 5 days, 7 days, 10 days, 14 days, 6 months, however long it's going to be. With disinfectants, we also have to think about this, and this is called the contact time or the dwell time. So again, if you look at your disinfectants that you have in your house, it's going to say kills salmonella in 30 seconds. That's the contact time. And what that means is that's how long a particular surface has to remain wet in order for the organism to die. So wet. That's very difficult to do, particularly with a wipe. And oftentimes you'll see people wipe an area and then dry it, right? So that doesn't allow for sufficient contact time, and the organism won't be killed. So, depending on the wipes that you use or the disinfectants you use, or if you wring out your rags that were pre-saturated with disinfectant, there may not be enough disinfectant on the surface to actually remain wet for that long. And that means a second application must occur, which is very difficult to implement from a process standpoint. So we looked at this as well, some new disinfectants, this particular improved or activated accelerated hydrogen peroxide product that had a substantially lower contact time that was necessary to kill the organisms we were interested in. We looked at this in an operating room to see if we might be able to turn over that operating room a little bit faster, so we didn't have to soak everything and let it dry for 10 minutes. Now we could soak everything and let it dry for 1 minute. What we found was that it actually worked very well, but unfortunately over the course of a day, it didn't have as much to do with the particular product as it did with the process of the particular worker. So the compliance with wiping and disinfecting and cleaning the areas that needed to be disinfected and cleaned actually decreased over the course of the day. So much like any individual doing a similar job over and over and over again, it gets worse over time. So this is another concerning issue. Also, we have to think about how are we going to apply this particular product to an area. We talked a little bit about soft surfaces, which is important. And what kind of materials are we going to use? We're going to use a wipe, or we're going to use a spray. Are we going to use cotton, or we're going to use microfiber? So for dilutable disinfectants, we've relatively recently discovered, thanks to a couple of studies, including this one, that quaternary ammonium compounds actually get bound up into cotton fibers. So if you use cotton rags with a quaternary ammonium compound, then when you take that rag out and wipe the surface, the disinfectant doesn't get released. It's bound up into the cotton. So unfortunately, you end up wiping a surface with largely water because there's no disinfectant left. So over the course of a day, if you throw a bunch of rags, cotton rags, in a bucket, all that quat is going to get bound up into the rag, and you're going to be wiping everything with water. So this was a huge, huge issue, and this really switched a lot of processes over to using microfiber cloths as opposed to cotton. And microfiber can be pretty good as well. Even there's several studies looking at microfiber without a disinfectant, just the particular microfiber cloth on its own, and it can wipe up bacteria pretty well and clean an area even without disinfectant. So there are a lot of other dependencies when we talk about disinfection that are important to our antimicrobial stewardship activities. So particularly with dilutable disinfectants, water additives are a huge issue. So different areas are going to have soft water, hard water, additives to the water, extra chlorine, extra fluoride. All of these can impact the efficacy of the particular disinfectant. Also, organic material in the water, surface material. So is there blood, body fluids, whatever it may be on the surface that needs to be cleaned up first before it can be disinfected. A lot of disinfectants don't work in the presence of organic material. So you have to actually physically clean the area with a detergent first. Luckily, a lot of our ready-to-use disinfectants are what we call one-step disinfectants that clean and disinfect at the same time. But again, humidity, the pH of the surface, and temperature can all affect the efficacy of a particular disinfectant. So then we have to think about biofilm. So if you've ever unscrewed a P-trap or in your sink, you've seen a lot of this slime layer. And that's all biofilm. And biofilm is just a polysaccharide sugar sticky thing that bacteria can create. And what they do is they create that and then they kind of hibernate in there. They're not actively growing and they're just kind of hanging out. And every once in a while they'll peel off and start growing again and cause an issue. So the issue is bacteria aren't actively growing. And a lot of our disinfectants and antiseptics work and antibiotics work on actively growing organisms. So if they're not actively growing, you're not going to kill them, right? Plus, they're protected by this slimy layer. So a lot of things can't actually penetrate that biofilm. You have to use good old-fashioned elbow grease to scrub it off. Unfortunately, we see even higher level of resistance in biofilm, and resistance that we previously thought may not be possible to happen, like chlorine and heat. We have heat-resistant, chlorine-resistant organisms, Legionella and Listeria. This is all very, very concerning. One thing in the hospital setting, in the outpatient setting, we've talked a lot about is touchless disinfection. Ultraviolet light, vaporized hydrogen peroxide, aerosolized hydrogen peroxide. Particularly ultraviolet light is really taken a strong stand in healthcare. And unfortunately, this doesn't really control biofilm or bacterial growth. And there's a new cluster randomized clinical trial looking at ultraviolet light among other methods of disinfecting the healthcare environment, showing that really ultraviolet light probably doesn't work any better than just bleach. So really nothing is going to take the place of good old-fashioned elbow grease. And even with UV light in these touchless systems, the areas need to be disinfected and cleaned first before they can be used. So I talked a lot about our failures in antimicrobial stewardship. We do have one intervention that works very well, and that's de-escalation. This is probably the most effective antibiotic stewardship activity that we have. And de-escalation means you take an antibiotic that you're using that's very broad spectrum and you try to narrow it down and use an antibiotic that's going to kill less of your normal flora as quickly as you can. Again, oftentimes you need to know what organism you're trying to kill to do that. And this is good because in antibiotics we have different classes of antibiotics that have a different spectrum of activity. Unfortunately, with our skin antiseptics and disinfectants, these are all broad spectrum. They're there for the sole purpose of killing everything as much as we possibly can. So we can never de-escalate with our disinfectants and antiseptics yet. We don't have any narrower spectrum antiseptics and disinfectants. So what can we do? Well, these are things that we've been trying to do, and again, we need to start thinking outside of what we've been trying to do because it's clearly not working so well. Furthermore, to have a good antibiotic stewardship program or antimicrobial stewardship program, you need a lot of people and you need a lot of experts. Unfortunately, most healthcare environments, inpatient and outpatient, don't have the individuals that are necessary to build these programs. Infection preventionists, healthcare epidemiologists, infectious disease physicians, microbiologists, clinical pharmacists, and individuals with research capability. Because without research, you can't develop the new intervention and you can't evaluate the interventions that you're implementing currently. So here are some sources that you can go to for more information on antibiotic stewardship. CDC core elements, as well as the outpatient stewardship review if you choose to read the full review. So overall, although we've come a long way with our stewardship activities, we've done a lot of things. We know that a lot of it hasn't really worked very well, but we've tried, and this is a very good step in our ongoing prevention of development and selection of resistant organisms. So it'll be really important in the future to keep tabs on what we're doing, not just in terms of antibiotics, but also antiseptics and disinfectants. I urge you to do that at home as well as in the healthcare facility. Thank you very much.